pleasure for me to introduce Professor Jack Wells. He was also already introduced yesterday, that he gave a brilliant talk about membranous nephropathy. He's a professor of nephrology at Radboud University in the Netherlands. He performed his postdoctoral fellowship in Denver, Colorado, and he's chair and has been involved for all of his life in glomerular disease and the study, treatment and diagnosis. He has published more than 250 papers in the top journals from our specialty, and he will enlighten us about the minimal change disease and focal and segmental glomerulosclerosis, two phases of one disease. Thank you very much to take this task.
Dear colleagues, it's a pleasure to talk about minimal change disease and primary FSGS. And in this talk, I will try to convince you that minimal change disease and primary FSGS are two phases of one disease. You may all recall that minimal change disease and FSGS are considered separate disease entities. However, this idea is based predominantly on studies in children. Patients with an idiopathic nephrotic syndrome in childhood are treated with steroids, and in most centers, steroids are started without doing a kidney biopsy. If the patient responds to steroids, they are considered as being diagnosed with steroid-sensitive nephrotic syndrome. And these are patients with a diagnosis of so-called minimal change disease. If the children do not respond to steroids, they are diagnosed as steroid-resistant nephrotic syndrome. And in these patients, if a biopsy is performed, often FSGS lesions are found. So based on the findings in children, minimal change disease was considered a steroid-sensitive form of nephrotic syndrome, and FSGS was considered a steroid-resistant form of nephrotic syndrome. However, in recent decades, we have learned what is the cause of FSGS, at least for part. We are certain that FSGS develops as a consequence of podocyte depletion. And this was very elegantly shown in a rat model, where the authors used an immunotoxin to induce podocyte injury. And by changing the doses of this immunotoxin, they could induce various levels of podocyte injury. And what was evident is that if you induce podocyte injury and thus cause podocyte loss more than 30%, you can see that sclerotic lesions develop. And the more damage and the more podocyte loss, the more severe focal segmental glomerulosclerosis. So FSGS develops always as a result of podocyte depletion. 10 years ago, we provided this overview indicating that podocyte injury and podocyte loss is central to the development of FSGS, but there are many different causes of podocyte injury. And to the left, we have an immunological cause mediated by an as yet unidentified plasma permeability factor, which causes podocyte injury, massive proteinuria, and a nephrotic syndrome. In the middle panel, you can see that there are mutations in podocyte genes or GBM genes, which can cause FSGS. And to the right, we have the forms of secondary FSGS caused by maladaptive responses in patients who have experienced nephron loss. In these situations, we often think as being hyperfiltration injury. Primary FSGS is a clinical diagnosis and can only be made after exclusion of other causative factors. And the definition of primary FSGS is the patient who has an abrupt onset of the nephrotic syndrome, being characterized by massive proteinuria, low serum albumin, often hypercholesterolemia, and edema. Looking at the kidney biopsy, there should be diffuse process effacement and the GBM should be normal. We have to exclude genetic mutations by looking at family history. And also we must be careful because in patients with the Afro-American race, we often have ApoL risk variants which contribute to podocyte injury. The kidneys should be normal in size and there should be no evidence of disease-causing drugs or disease-causing infections. And defining primary FSGS in this way means that we identify or define a disease which is probably caused by circulating plasma permeability factor, which is evidenced by the fact that if we perform a kidney transplant in these patients, there is a high risk of a recurrence. In our proposal, we suggest that minimal change disease and primary FSGS are actually variants of one disease entity. We hypothesize that the clinical features and also the histology is dependent on the intensity of the podocyte injury, the severity of podocyte depletion, and the sensitivity to corticosteroids. And in this diagram, you can see that we think the disease starts with minimal change disease. If you have more intense podocyte injury, often characterized by more severe proteinuria, you can develop the TIP variant or the collapsing variant of FSGS. If you have progressive podocyte depletion, you will develop sclerotic lesions and finally develop FSGS not otherwise specified. And if you lose sensitivity to steroids, there will be resistance, you will develop renal insufficiency, end-stage renal disease, and finally receive a kidney transplanted with a high risk of disease recurrence in the allograft. So what about the proof or the evidence? Well, there have been various remarks made by various authors suggesting that these diseases are different because there are differences in pathology, clinical outcome, the presence of circulating markers, differences in genetic mutations, and also people have looked at differences in animal models. Although I must admit from the beginning, there are no animal models of steroid-sensitive nephrotic syndrome and minimal change disease, so it's very difficult to compare these diseases in an animal model. I will provide you some arguments to provide evidence that minimal change and FSGS are in fact not different diseases. With respect to pathology, it's clear that minimal change disease is characterized by the absence of abnormalities in light microscopy. In electron microscopy, there should be complete food process effacement. However, to diagnose FSGS, you only need an abnormality in one glomerulus. So most glomeruli in patients with FSGS have a similar histological features as in patients with minimal change disease. The abnormalities in FSGS originally were described in children and were characterized by sclerosis, hyalinosis, the presence of foam cells, and the remarkable synechia, the adhesions between the capillary tuft and Bowman's capsule. However, in 2011, pathologists convened and proposed a new classification, the so-called Columbia classification. And interestingly, this Columbia classification no longer requires sclerosis to diagnose focal segmental glomerulosclerosis. And this makes it even more problematic, I think, because in this classification, we have the tip lesion variant, the collapsing variant, and the cellular variant. All these variants do not have sclerotic lesions. They are characterized by proliferation of parietal epithelial cells and podocytes. So there is an overlap in histology, but there is also an overlap in clinical outcome. In children with steroid-sensitive nephrotic syndrome, which may be the same as minimal change disease, these children have a very rapid response to corticosteroids, and they can develop a remission within 4 weeks. However, the situation is clearly different in adult patients with minimal change disease. In adult patients with minimal change disease, it can take 16 weeks before developing a remission, if at all. And then if we look at patients with FSGS, and I put it as red stars in this slide, patients with FSGS also can develop a remission of proteinuria, but it takes longer than in adults with minimal change disease. But actually there's a large overlap, meaning that some patients with FSGS respond very quickly, whereas others do not respond at all. And it's only a matter of balance. I think in minimal change disease, the response rate is a little bit better than in patients with FSGS, but there are no major differences. Just the timing to develop a remission is different. And I went back to the old literature, and I can show you that in the original publication of Rich, where he described FSGS, there was a relationship between the severity of FSGS and the duration of the disease, meaning that in patients who had a very short follow-up when the biopsy was done after disease onset, in these biopsies, no abnormalities were found. So these patients should be classified as minimal change disease. However, in patients often dying with long follow-up because of severe nephrotic syndrome, at autopsy, severe lesions were found, especially in children with a prolonged disease course. So this slide nicely reflects that with more prolonged disease, you are more likely to develop FSGS lesions, and the longer the duration, the more severe the lesions. This study of Tejani, published in 1985, I think is even more convincing. So these authors identified patients with so-called minimal change disease, and they were all steroid sensitive from the beginning, but they had frequent relapses and were followed for more than 5 years. And these patients were biopsied initially 1.5 years on average after onset, and they were biopsies because of a relapse. And in these patients, at 1.5 years after disease onset, all had minimal change disease, so they glomeruli look normal. Then patients were re-biopsied during the course, and in the second biopsy, which was taken 4.5 years after the first biopsy, focal segmental glomerulosclerosis was observed in 45% of these patients. In a smaller group, biopsied for the third time, on average 5 years after the second biopsy, the percentage of FSGS was 83%. So this study clearly demonstrates that in children with minimal change disease, initially steroid responsive, but with frequent relapses, there is more and more evidence of FSGS lesions, the longer the duration of follow-up, and thus the longer the duration of proteinuria. Then the circulating permeability factor, which might be present in FSGS and not in minimal change disease. Is that true? Well, in fact, we know that there should be a circulating permeability factor. There is evidence based on clinical observations about early recurrence after transplantation and the efficacy of plasma exchange. However, thus far, the causative permeability factor has not been identified. And in fact, in all studies, it was also suggested that in minimal change disease, the circulating factor was present. And when SUPAR was proposed as permeability factor, we measured SUPAR in patients with FSGS and also in patients with secondary FSGS and patients with minimal change disease, and we could not find a difference. So for now, I would say there's no evidence that minimal change disease and FSGS can be differentiated by measuring circulating permeability factors. Then polycyte loss. FSGS is considered the result of podocyte depletion. What about podocyte loss? The group of Wiggins at Michigan have measured podocytes in the urine. And this slide showed the number of podocytes in the urine based on the measurement of mRNA for podocin. And they looked at patients with FSGS, patients with minimal change disease, and patients with nephrotic syndrome, either steroid resistant, steroid dependent, or steroid sensitive. And they divided the patients in states where they had proteinuria or where the patients were in remission. And what is clear from this figure is that if the patients do have proteinuria, the rate of podocyte loss is higher than when the patients are in remission. However, when you compare the various diseases, there are some differences, but in patients with minimal change disease, there is podocyte loss. And there is actually no difference between patients with minimal change disease, patients with FSGS, non-progressors, patients with steroid resistant, and patients with steroid sensitive nephrotic syndrome. So this signals, or this provides evidence that proteinuria is associated with podocyte loss independent of the underlying histology. This also suggests that minimal change disease, which is not treated, will in the end cause ongoing continuous podocyte loss, which, according to the theory, always should lead to FSGS. What is also important are the recent studies that looked at disease recurrence. Theoretically, we would expect that the patients with FSGS who are steroid resistant and develop end-stage disease should be the ones who develop recurrent FSGS after kidney transplantation. Here you can see in this slide the percentage of patients with recurrent disease after kidney transplantation, classified according to initial histology or initial steroid responsiveness. And in the first three bars, you can see that there is no recurrence in patients who present with congenital nephrotic syndrome. These are the patients with a mutation in nephrin, and we don't expect recurrence. However, if we look at the initial histology, then the recurrence rate, provided by the black bars, is higher in patients who start with minimal change disease histology than in patients who start with FSGS. And most importantly, if we look at steroid resistance, then the authors differentiate between primary steroid resistant nephrotic syndrome, so these are patients who never responded to any treatment with steroids, and patients with late steroid responsive nephrotic syndrome. So these are patients who present with a steroid sensitive nephrotic syndrome, but they lose their steroid sensitivity during follow-up and eventually develop steroid resistance and develop end-stage renal disease. And this figure clearly shows that the recurrence rate is higher in patients with secondary or late steroid resistance. So the patients who are initially steroid responsive and have an initial histology of minimal change disease, but develop late steroid resistance, they are at risk for disease recurrence. What is also interesting is what we can learn from patients with recurrent FSGS. You all know that if you transplant a patient with primary FSGS, or so-called primary FSGS, then these patients can develop a recurrence within 1 week. If you do a kidney biopsy in the early phase, you always see a pattern which is compatible with minimal change disease, because you don't see abnormalities in the glomerulus, you only can find food process effacement. And in this slide, one of my co-workers compared the histology in the native kidney biopsy with the histology in the first biopsy taken after disease recurrence. And you can see we had various group of patients, either with minimal lesions, glomerulopathy, tip lesions, perihilar glomerulosclerosis, collapsing glomerulopathy, and FSGS NOS in their native kidneys. And if we then looked at the allograft biopsy at the time of recurrence, most of these patients had no glomerular abnormalities. So, although we call this recurrent FSGS, there is no evidence of any FSGS lesion at this time point. We also looked at repeated kidney biopsies in patients with nephrotic syndrome and either minimal change disease or FSGS. And we compared patients either repeated biopsies of native kidneys biopsies or repeated biopsies in transplant kidneys. And this figure shows you this change in morphological appearance. So some patients started with minimal change disease, minimal lesions, and in repeated biopsy, they had either tip lesions or collapsing lesions, and some had FSGS NOS. What this figure illustrates is that these points always go in one direction and they end FSGS NOS. So minimal change, tip lesion, collapsing lesion. If there's progression, you get a sclerotic lesion, and there's never a return of this morphology. Interestingly, we have a comparable entity, which is membranous nephropathy, where patients have a nephrotic syndrome. And if you do a kidney biopsy, you often find FSGS lesions. This is one example, but there are more. But in this study, in 156 patients, 23 patients with membranous nephropathy had FSGS lesions. And not unexpectedly, the patients who had evidence of FSGS lesions had more severe renal insufficiency, had more often hypertension, had more often hematuria, and importantly, they had a larger glomerular volume, suggesting that in these patients already there was evidence of glomerular hyperfiltration. Still, in these patients, I think you all agree that the diagnosis in these patients is membranous nephropathy and not FSGS. Why would we then differentiate minimal change disease and FSGS? Finally, are there no lessons from animal models? Well, I have found one interesting animal model which could help. As already alluded to in my introduction, there is, in my view, not a good animal model of minimal change disease. Most animal models with persistent proteinuria actually are models of secondary maladaptive hyperfiltration FSGS. However, there are some models. One model is the Priomycin amino nucleoside model, where the dose of the toxic agent depends or predicts the duration and the severity of proteinuria. And I think the best example is a recent study which studied proteinuria in the RAC1 transgenic mouse. And this model is a model where there is podocyte-specific overexpression of a small GTPase, RAC1, and based on this transgene expression, you can identify low and high responders based on the copy number of the transgene which is expressed. And if you have low responders, you have limited proteinuria, and if you have high responders, you have more severe proteinuria. In these high responders, in the initial biopsy, 5 days after onset of proteinuria, you will find minimal change disease and focal and food process effacement. After 30 days, you will see the development of sclerosis. This model is inducible, meaning that you can induce the expression by feeding the animals doxycycline. And this is interesting. If you withdraw the doxycycline, the expression of the RAC1 will disappear. And then if you treat the animals with doxycycline for a short time period and then withdraw the drug, you can see that there is increasing proteinuria, and after 5 days you see a rapid decrease in proteinuria, and in humans we would call this remission of proteinuria. In the lower responder mouse who do not develop severe proteinuria, you can see the same effect. You can see that proteinuria increases, but if you withdraw the doxycycline, there is a remission of proteinuria. If you use the doxycycline for a more prolonged time period, so in this case 14 days instead of 7 days, you still see the induction of proteinuria. But then if you withdraw the doxycycline, there is no complete remission again. And this, in my view, recapitulates a little bit what we see in minimal change disease. If you have a response to steroids, you will develop a remission. If you develop a complete remission, you are not likely to develop FSGS. However, if you have minimal change disease with a relapsing course and sometimes not reaching complete remission, you are more likely to develop FSGS lesions. So in conclusion, it's evident, and you all know, that FSGS is not a disease. I think it's clear that FSGS with sclerotic lesions signals podocyte loss. And proteinuria also signals podocyte loss. So patients with proteinuria are prone to lose podocytes. And if that process continues, you have podocyte depletion, and severe podocyte loss and podocyte depletion will cause FSGS. So what happens in minimal change disease? You have proteinuria and podocyte loss. If we are able to stop that process with steroids or other treatment, you will have remission and no subsequent damage. However, if proteinuria persists for a long time, or you're not able to reduce proteinuria and not able to induce a complete remission, you will have ongoing podocyte loss and finally develop focal segmental glomerulosclerosis. Obviously, patients with minimal change disease who develop minimal change disease above when they have pre-existing nephron loss, then they will be more likely to develop FSGS. And that's one of the reasons maybe that patients who are born with small-sized kidneys or born with low birth weight, they have a less amount of glomeruli and a less amount of nephrons. If these patients develop minimal change disease, they are more steroid resistant and more likely to develop FSGS. So I hope I have convinced you that we should have a different look at these two entities, minimal change disease and primary FSGS. I think it's reasonable to think about these diseases as a continuum. And I end my talk. I thank you for your attention, and I'm open for questions. Thank you very much.
Thank you very much for your nice presentation that actually enlightened a little bit this dark phase of the nephrology, because we do not know. We are happy now because in membranous nephropathy we have at least a marker. What do you think that will be the new biomarker in this disease? Do you have anything in your mind?
Actually, no, unfortunately. I think the biggest problem is that we have not a very good model or model systems to study the biomarker. I'm not sure that the circulating factor is the same in every patient. It might be different. It might be an activity which changes other proteins. And in my personal view, I really like the idea that the circulating factor is more a complex of proteins which are complex, and you have binding ligands, and that may be one of the reasons that we are unable to find this factor with the current techniques, because we are looking for one single protein, and maybe it's an agonist and an antagonist which are in a kind of balance in normal human people. And in patients with FSGS, there is a disbalance. But I have no clue what the factor could be.
And what do you think about the apolipoprotein A1B that has been described mainly in urine? What's your opinion?
Well, I think it's an interesting finding, and it should be validated. What is interesting, I think, is that it's something in the urine which suggests that it might not be the circulating factor, or it might just a product which is produced or cleaved. And hopefully it will enable us to select the patients who have this circulating factor, and maybe by looking specifically at the patients with the highest activity, we can find something in the serum.
Okay, coming new questions from Professor Praga. Excellent talk. Do you think rituximab should be tried it in the minimal change disease in native kidneys, showing corticosteroid and calcineurin inhibitor resistance?
Actually, I think that if you have a patient who is really resistant, then I don't think that the likelihood that rituximab will work is very high. But I think the problem is that many patients with minimal change disease or FSGS, they are, let's say, have less responsiveness to steroids, but they respond very slowly. And in these patients, I think then you can have advantage of rituximab. But these patients are B cell dependent, but you know, it takes a long time. And I have some experience that in the past we used like mega doses of pulse solomidrol, methylprednisolone, like 30 pulses, the old Mendoza schedule, and that also sometimes worked. So I think in these patients rituximab could work, but if you have real resistant disease, no effect of prednisone at all, I'm very skeptical that it will do anything.
Another question, any idea why secondary focal segmental glomerulosclerosis has this hypoalbuminemia? Why this nephrotic range proteinuria?
Yeah.
Is because there is maybe the circulant, maybe the biomarker that is altering that, or?
Well, personally, I think that maybe it's something to do with physiology. So if you have primary FSGS and you look at the kidney biopsies, you can see that all tubules are very active and are loaded with proteins. And if you look at patients with secondary FSGS, you have already have often a lot of interstitial fibrosis. And my personal feeling is that the tubular metabolism of albumin is lower in patients with secondary FSGS. So that could be one option. The second one is that there are suggestions that the podocytes also can take up proteins and albumin. So maybe there might also be a difference in podocyte albumin metabolism. But since the podocytes are so few cells, personally, I have the feeling that it's maybe the tubular metabolism and the proximal tubular cell albumin uptake.
Maybe it could be the explanation of that. Another question from Leonela that she's asking us, why do you think that the measurement of the podocyte loss could be useful to detect if we are in front of the advanced disease, if we are in front of the one that will have recurrence after kidney transplant?
Well, so I think we are trying to study that now, but there are two issues, I think. One is that you can measure podocytes probably in the urine and have an impression of podocyte loss. But the studies which have been done in the United States by Wiggins group, they actually show that if you look very critically, there's a very nice correlation between proteinuria and podocyte loss. So even patients with minimal change disease, they lose podocytes. I think the problem is, and maybe we should look more at that, the issue is if you lose podocytes, it's not bad if you have enough at birth. So, but if you have very low birth weight and you have a limited number of podocytes and you start to have minimal change disease, you might more quickly go into FSGS. And the problem is we can try to measure podocytes in the urine, but then we should measure it repeatedly. But we are not able to really, I think, estimate very correct the number of podocytes in the individual kidney.
That's good. And with the level of proteinuria, do you have the feeling that the patient that starts with worse proteinuria, less albumin, serum albumin, this patient will relapse, will be worse?
No, because I think there are patients with minimal change disease who would do very well, and they sometimes have the most severe proteinuria. I think what is very important is that it's probably not the total amount of protein, but it's the amount of non-albumin protein. In my view, albumin is albuminuria is not a problem. It's the loss of higher molecular weight proteins. And so some patients have massive proteinuria, but they are very selective proteinuria, and they normally don't have that much injury and not that much progression. And that's the reason that in the past, selectivity index also has been used to tell something about the outcome in patients with minimal change disease.
Okay, another question from Jorge Rojas. Some case studies have shown beneficial effects of rituximab in minimal change disease. Will this fact lead to a more relevant role of B cells and to mediation by autoantibodies? What's your opinion on that?
Yeah, so I think B cells might be very important, but I doubt if it's true the production of autoantibodies. Maybe the B cells are important because they interact with T cells. I know that there are some hypotheses about the role of antibodies against CD40 and other components in the patients with FSGS and minimal change disease. My question is, if you have antibodies like in membranous nephropathy, we always can find the antibodies bound to the podocyte or bound to, the structure and the GBM or whatever. If you have antibodies which are important in minimal change disease and FSGS, why don't we find something on the podocyte? Normally, they should bind.
That's right. And we don't have more questions. Actually, we are on time. Thank you very much for your nice presentation. Okay,
thank you very much. It was nice to be there virtually, and hopefully one time I will be back live.
We hope so. Bye-bye. Thank you.
Okay. All the best to you. Bye-bye.
Same to you. Bye-bye.